Welcome to Massey College. Bienvenue. And welcome to the series called Massey Loves to Read, where we read good and informative books that help us continue to survive the pandemic. And this one today is particularly important for the future of our healthcare system. So I'm delighted to welcome you all to Massey College. Massey College, as you know, is built on Indigenous land, the land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. We want to acknowledge our duty to steward the land and also the great privilege that we have to continue to be here and discuss good books. So today we're going to talk about a book called Remaking Policy, Scale, Pace, and Political Strategy in Healthcare Reform. It really is a fabulous, impressive book that has won prizes that by our senior fellow, Carolyn Tuohy, and we'll be discussing with her the big ideas of this book, how it came to being, and what does it mean for the future. We'll be joined as well by Haviho Sek, who has worked all her life in the field of policy and politics in Canada. So let me first introduce fully Professor Carolyn Tuohy, who's a professor emeritus of political science, distinguished fellow at the Munk School of Global Affairs and Public Policy at University of Toronto. She specializes in comparative public policy. And she is also, she's just recently wrote something for Policy Option on reform of the long-term care policy in Canada. And we know that she's also working on a book on narrative discourse in public policy. She's a founding fellow of the School of Public Policy and Governance. And also she is a senior fellow at Massey College and a fellow of the Royal Society of Canada. Welcome, Carolyn. Such a pleasure to have you to discuss your book. I'm delighted to have you. And
thank you. So
go ahead.
No, so, you go ahead.
No. So, and I want to welcome our commentator, Haviho Sek, who's worked at the nexus of policy and politics. She's done this while wearing many hats. She was a feminist activist, an Ontario provincial politician. She was the director of policy and research to the Prime Minister of Canada. She was the CEO of a Canadian-based international research organization, CFAR, that we know very well. She's the board member of several business corporations and a professor of public policy. She is a senior fellow at Massey College, and I'm so delighted to have her participate in this discussion. So without further ado, let's pass it to the author, Carolyn, to explain to us a little bit the vision of this book and really the models that it puts forward and really some of your conclusions. Carolyn.
Thank you so much, Natalie, and thank you for the opportunity to present the book and to exchange with two colleagues whom I so greatly admire and others on the call. I prepared some speaking notes because this is a hefty book. This is 700 pages or more, and so to summarize it in a short compass is quite a challenge. So I'm going to refer to some speaking notes, but also as we get into it, to show a few slides and hope that just sets up a conversation. So I wrote this book for the reason that most academics write books, which was to scratch an intellectual itch, to deal with something dissatisfying about the way the current literature dealt with a phenomenon or some puzzle that can't be explained with existing frameworks. And in my case, it was a literature on patterns of policy change, including my own contributions to that literature, which focused on two patterns of change, either slow incremental change over time or sudden Big Bang change that departs from an established policy path. And that literature has given us some very rich descriptions of the policy process. But there's a problem. in that dichotomy between Big Bang and incremental change just doesn't exhaust the range of possibilities. How would you explain, for example, Obamacare? It wasn't Big Bang. It targeted only about 10% of the population in terms of improving coverage. And it left in place the existing institutions of the employer-based healthcare system and targeted government programs. So it wasn't large scale, but it also wasn't slow. It was a lot of small scale changes very fast. Famously, more than 1,000 pages of legislation. So Big Bang versus incremental doesn't work very well for Obamacare, nor does it work very well for how the Dutch reformed their healthcare system, which was to secure agreement up front on a major large-scale change, moving from a dual system of social insurance for part of the population and private insurance for another part of the population, to a common platform of common entitlements and common rules for all insurers, from a dual to a universal system. But they did it over 20 years. So it was large scale, but put in place over a long period of time. Longer, to be fair, than originally intended, but it was always intended that it would be in stages over time. So as I wrestled with that recognition that our existing frameworks just didn't do well in explaining certain cases of change, there were a couple of key insights that I developed. In the first place, we need to distinguish between what opens a window of possibility for big change, for major change, path-departing change, as political scientists would say. So what opens the window on the one hand, but then what determines what happens after the window is open? And the principal insight is, as I looked into this, and I didn't actually start with this insight, but as I looked into it further, the processes further, I became persuaded that we need to see policy change as a matter of political strategy at the center of government. Politicians acting in their partisan interests at the center of government in response to conditions of the time, and how they read the conditions of the time, not necessarily in some sort of objective sense what those conditions are. So a window opens when the government of the day believes that it's in an institutional position in which it can mobilize a coalition around path-breaking change, and it has the partisan incentive to do so. And the partisan incentive is key. No government is going to take on major change, discontinuous change in an area as politically sensitive, publicly sensitive, and fiscally important as healthcare, unless they see it as central to a partisan agenda that is going to benefit them. But once the government of the day sees a window of opportunity, believes that it can mobilize a coalition, and that it has a partisan incentive to act, they still have to make some strategic decisions. How big a change do they want to make, and how fast do they want to make it? So this brings me to the subtitle of the book, Scale, Pace, and Political Strategy in Healthcare Reform. Let me say a bit more about what I mean by scale. I don't mean turning on and off the fiscal taps, as important as that may be. I mean fundamental change in the way decisions are made about allocating resources in the system. Those basic political questions of who gets what, when, and how. Who makes those decisions? What's the balance of power? In healthcare, that means what is the balance of power between the state, the medical profession, and private finance? And how do those decision makers enforce their decisions, whether through hierarchical rules or market mechanisms or peer control? And finally, what are the legitimating principles? What are the principles of entitlement to benefits, and who is obligated to provide those benefits? So those changes in the power balance, in the enforcement mechanisms, and in the legitimating principles constitute the scale of change that I'm interested in. The pace is more simply how fast the change is hardwired by being enacted into legislation, all at one go, in stages over time. And if in stages, does the time frame extend beyond the life of a single government? Or will the government have to face the electorate before completing the process? So with those distinctions in mind between scale and pace, we have 4, not 2 possibilities. And Matt, if I could have the slide now. The next slide, please. There we go. So there are the 4 potential strategies of change, depending on the scale and pace at which it is attempted. So large scale, rapid change is Big Bang. It replaces existing institutions with new institutions in a single sweep. It is extremely ambitious. Mosaic change, such as Obamacare, which I described, is a lot of small scale changes, but very fast. It departs from the path in speed, but not in scale. But you can also, as the Dutch case I mentioned demonstrates, make large scale change gradually, crucially extending beyond the life of the enacting government. And the change, and this is crucial, the change is enacted over a period of time. It's not all hardwired up front. It is actually enacted in stages, not just implemented in stages. And finally, of course, you can have small scale, gradual change. But the key point in my book is that we can't just assume that because we observe small scale incremental change, there was no opportunity to do anything else. In fact, I give a couple of cases in which there was an opportunity to do, the government did have a window of opportunity for change, perceived that it had a window of opportunity for major change, and yet still chose to go incrementally. Could I have the next slide, please, Matt? So I populate this space with 10 cases of health policy over 7 decades in 4 countries. So it's hence the 700 pages of the book. And I explain these patterns, the emergence of these patterns, in terms of the political perceptions and strategic calculations made by politicians at the center of government as to how well they are positioned to overcome the vetoes that can stymie change in healthcare, how well they're positioned to overcome those vetoes in the present, and how they project the likelihood that they're going to maintain a position of power into the future. And depending on how they read their prospects, they will choose their strategies accordingly. So if you have the capacity to mobilize a coalition and can command that coalition around a common position, and that would typically be a majority government, but not necessarily a majority government. If you can command support for a common position, you can do large-scale change. Or if there is a temporary alignment of interests among independent players whom you can't control, but you can forge a consensus around a common position because of an alignment of interest, you can still do Big Bang change. So an example of the first case, being able to command a coalition, the quintessential example is the founding of the British NHS, National Health Service, after the Second World War. A massive landslide election for Labour. They come in with a majority government. They've got a clear incentive. They see healthcare as central to a social policy agenda, and they move very, very fast. But we also see a big bang in Canada in the 1960s, when a federal minority government is able to negotiate the framework of universal physicians insurance with the provinces. And in that case, it's because of an alignment of interests. This was a period of province building in which provinces were eager for federal resources and were willing to do that deal. Okay, that's Big Bang. Mosaic change. A government finds itself in a position in which it can seize a moment but it cannot command a coalition, nor is there a strong alignment of interests. Rather, the government has to cobble together a coalition by doing multiple deals. This is the case of Obamacare, when for a brief shining moment, the Democrats controlled the White House, both houses of Congress, with, for an even briefer moment, 60 votes in the Senate to overcome filibusters. And they had to cobble together an internal coalition, an internal Democratic coalition of many small deals to accomplish Obamacare. In both of those cases, in the Big Bang and the Mosaic, politicians know that they have a temporary advantage. You go to Ruud Lubbers in the Netherlands in the late 1980s. Here's a Christian Democrat prime minister heading a center-right coalition. He knows that his party has been somewhere in a coalition government since 1918, and he doesn't project losing that authority anytime soon. Turns out he was wrong, but he doesn't, for understandable reasons, he doesn't project that he's going to lose authority. And he's able to secure agreement around a common framework to transform the health system. But part of the agreement is it will only be enacted in stages as conditions warrant. And his partners in Labour and in the so-called social partners in the Netherlands, Capital and Labour, are confident that they'll also be around the table as those stages come to fruition, given the Dutch tradition of coalition governments and corporatist decision making. So they're actually able to bring about a blueprint change that transforms their system in stages over 20 years. They originally were targeting something like 5 years. It turns out it took considerably longer, but it worked because that upfront agreement established what I call a shadow of the future, under which all the players in the healthcare system began adjusting their behavior over time and essentially making inevitable the ultimate resolution. And then finally, and this was an insight that I did not expect to come up with in the book, you can have a strategic decision in a window of opportunity to continue with incremental change. And a Canadian example there is Paul Martin in 2004, in which Martin sees a strong partisan incentive for himself to establish his own stamp on the party by coming to an agreement with the provinces on long-term care, on health care. But he believes that he is at the beginning of a long period of tenure as prime minister, and he believes that he will be in an even better position after he wins his first election, which was at that point was planned for June 2004. So he convenes a meeting of first ministers in September 2004 with the expectation that he will be in a better position at that point. But his strategy is to make an upfront investment in healthcare that will position him even better with the premiers by earning him some goodwill by restoring federal transfers, and then addressing some of the larger scale changes to the system. Now, the world didn't unfold the way Martin expected, but he had every reason to think that it would at that time. So those are my cases, and we can certainly discuss and debate them later in this session. But now, Matt, if you could just go to the last slide. So what can we expect now? And what are the possibilities now for policy in the wake of the pandemic? Next, Matt. I would argue that where we are right at the moment is in mosaic territory, that things are so uncertain that politicians are very unlikely to make large assumptions about their ability to forge consensus and to sustain their position over time. And what we are seeing, I believe, as a consequence, is a lot of coalitions of convenience working through existing channels to stimulate the economy, but little in the way of really transformative long-term change. So I think we're going to have to wait for post-pandemic elections and have governments then assess where they are, how they are positioned to overcome vetoes in the present and over time. So next, please, Matt. So it could be that governments are either rewarded or punished on a major scale for their performance in the pandemic, and that we have a set of landslide elections. It looks so far as if incumbency is being rewarded in the few elections that we've had so far, including just the most recent Scottish, Welsh, and English local elections. But we don't. But it remains to be seen whether incumbent governments are indeed rewarded or punished. But if they find themselves with large majority governments, they may move to in a big bang direction to introduce entirely new institutional frameworks. One example could be a basic income, not just in Canada, but elsewhere. Next, please, Matt. Or they may anticipate the recovery and anticipate that they will be in a better position after a period of economic recovery and make down payments, make a particular investment that will provide a platform on which they can build in the future without establishing a blueprint, just giving themselves a platform on which to build. And long-term care could well be an example there of making some initial investments. I would argue if they're going to do that, it should be an infrastructure, and then set out a process for a strategy, a longer-term strategy. Or final, yes, it may be that many of those who are talking about a transformation of the policy landscape because of the COVID experience are right, and that there is a broad consensus emerging on a new model, such as a Green New Deal, that could be agreed upon up front and enacted in stages over time. That's a possibility. I don't expect it to occur. I believe that consensus needs to be filtered through political incentives in such a way that we're not likely to end up in blueprint territory. But these are at least possibilities that we could discuss. So I think I'll leave it at that and see what my discussants have to offer on this, and very much look forward to that exchange. Thank you.
Oh, thank you, Carolyn. It's such a wonderful idea. What a wonderful theory, actually, to start exploring both the past and imagining the future. So it's been quite stimulating to read and quite stimulating to hear you describe it. So let's move to Haviva. So does it speak to you? Does the model speak to you? And how do you see it responding to some of the things that you've lived through?
Well, the model is very rich and very nuanced, and there's no way I can do justice to it. So my strong advice to everyone who's interested in this is read the book. However, part of what, and all the political things that I know about, in particular, the history of Canada in 65, 66, and then the whole process of federal provincial dickering around healthcare issues, plus what happened with Mr. Martin in 2004. Everything I actually know about, I completely agree with what it is that Carolyn has described and the way in which she's described it. I'm also interested in the moments in which some of this arose, and she's talked about political power, but I want to start with social solidarity. The reason that Clement Attlee won the election as big as he did, and the Labour Party in Britain was able to bring in the National Health Service, is because of the strong sense of cross-class solidarity that had been created in Britain because of the war. And it's important because they had survived horrors together, and also the horrors came from outside. So they had lived together across in a very class-ridden society, still a very class-ridden society, and the National Health Service arose out of that moment of solidarity. The other moment I want to talk about is Lyndon Johnson's, the things that he did in the 60s, the Voting Rights Act, and forgotten the name of the other, and the Civil Rights Act. Let's not forget that he too came to power after what was seen as a national tragedy, which was the assassination of President Kennedy. And I think it's the combination of Lyndon Johnson's incredible diabolical political skill and the moment in which he was governing at that point that made possible the things he tried to do. He didn't go very far on healthcare. So when I think about what happens next, for those of us who've lived through the pandemic together, do we have increased social solidarity or not? I wish I could say that I'm certain that we do, but because of the way in which the pandemic has played out and because of the internal fissures in our societies that it has revealed, and I would say much more in the United States than in Canada, but still, it doesn't feel as if everybody's been on the same side, if I may put it that way. Big surprise to me, but nonetheless, it doesn't feel as if absolutely everybody's been on the same side. So one of my questions about what's next is certainly Carolyn's questions and the layout that she has of what might happen next, but also how much social solidarity will our societies feel after this is over? And what are they prepared to invest in and build? And when I worry about how we will be able to do anything, part of what this catastrophe crisis has revealed to all of us are the incredible mistakes that governments have made, the inability to deliver what they said they could deliver, the weakness of some of our institutions. Let me use as an example the long-term care facilities. So even though we have a narrative of heroism, and you know, it's an appropriate narrative of heroism, from the people who've been able to create vaccines as quickly as they have, to the doctors and the nurses and the various other people giving people care, but there's also a narrative of internal social fissure and people not wanting to play by the rules. So it's not it's not the same as 1945-46 after the Second World War in Britain. And so I think that will somewhat condition what we're prepared to do and what institutions we're prepared to build. What I'm really trying to do is bring a sense of the historical moment as well as the political moment into what we can imagine for the future. I wish I knew the answers to these questions, but it isn't worth asking questions to which you already know the answers. So let me stop there.
Yeah, unless you're a lawyer, where that's the only skill that you're
yes, and I am not a lawyer.
So let's bring in Carolyn here, and let's wait. So Carolyn, what do you make of this idea that it's not just a political opening? It almost needs to be a deep moral sense of solidarity, and whether that plays out in your model somewhere.
So Haviva's terrific point raises another dimension of the book, and another dimension of decision making, which is what I call the direction of change. So in what I've said so far, I've only talked about how big do you go, how fast do you go, but in what direction are you moving? And that very much, I think, has to do with the times, with the historical moment. And if you, but even so, that direction can be filtered through the strategic calculus that I've described. So let's take the NHS in the UK and Medicare in the US, and you see in both cases immediately after a landslide election, right? So Labour in the UK has a landslide after the war and a large social policy agenda. Lyndon Johnson has a landslide after the '64 election and a Great Society object. However, you get two different results. Exactly. You get, in the British case, a national institution, a true Big Bang. In the US case, you actually get a mosaic. You get Johnson piecing together proposals from different parts of a coalition that he has to build to create what has classically been called a three-layer cake of physician insurance, hospital insurance for the elderly, and physician and hospital insurance for certain categories of the poor. But it's basically a mosaic. It's not a transformation of the employer-based system in the UK. So I absolutely agree that to give the full picture, you have to look at the moment and what the ideas of the moment, the sentiments of the moment are historically. Many of my more recent cases are clearly driven by a swing to a greater infatuation with the market in the 80s and 90s in healthcare. But even so, that, took a blueprint form in the Netherlands. It took another big bang in the UK. And it took a mosaic form in the US. So these big changes are filtered through a political calculus. Yeah.
Yes, of course.
So is it possible to have Big Bang in a context of very polarized society? I was struck by the fact that your examples of Big Bang, which, as I have to say, because I'm a law reformer, we kind of like that. We like big transformations as opposed to a mosaic that makes a real mess of all these statutory enactments. But so is it ever possible to imagine that there are going to be still other Big Bangs? Because we have a sense, and I think Haviva was mentioning this, that we're more polarized. We're not pulling in this together as we tend to assign blame. So is it, am I right to think that the Big Bang era is maybe behind us?
No, I don't think so. It is possible to have Big Bangs in a polarized context as long as one party can at least temporarily find itself in a position in which it can mobilize that coalition and drive through the change. So as an example, Australia went through a series of big bangs in healthcare over a very polarized period between the parties of the left and the parties of the right. Parties of the left would come in and introduce universal insurance. Parties of the right would come in and undo it. Parties of the left would come back and redo it. So until about the 1990s, when I think they finally just exhausted themselves with these reverberating changes, you actually had a series of big bangs. It's a reason why governments that enact big bangs and see themselves as temporarily in a position of advantage will also try to implement them really fast, to build it into the system so it's harder to undo through legislative change.
So, feel free to come in and comment. I was going to go through the electoral system aspect, because that's the other issue that when I was reading, I thought, oh, we actually, as you described, because our first past the post rewards government with large majority when they may not be. So that would militate for your argument that, they should do a big bang because they have almost an unwarranted opportunity to do so, and they should take advantage of it, but they don't, or they are hesitant. Did you factor in the electoral system at all? Yes.
Yes, indeed. I mean, it certainly is the case that that certain systems are more prone to one of these models than others. So a first past the post Westminster system is going to have more big bangs. Then it depends how the politicians read these circumstances, however. Keep that in mind. It's not just the objective institutional configuration, it's how they read their advantage. But yes, I mean, a first past the post Westminster system is more likely to generate big bangs. A congressional system in the US, much more likely to generate mosaics, etc. In the Canadian system, we have a Westminster system. So you might expect to see more big bangs at the provincial level, but we're with the governments with jurisdiction over healthcare, but we are into a federal mix as well, and so that has tended to push us to more incremental changes. Although, we did have the creation of Medicare in the first place, but that was such an unusual moment. Back to Haviva's point, such an unusual period of cooperative federalism after the Quiet Revolution in Quebec and the advent of a new cohort of premiers that were committed to province building. Such an unusual time.
So what do you think, Haviva? You were there. Yeah, but not at that time, but go ahead.
I want to give you the magic words. Tommy Douglas, who is still considered by most Canadians the most important, heroic, wonderful person who ever lived in Canada. And there are days that I agree with them. So that was an interesting moment, 65, 66, when when Medicare was created. I betray my previous history, including my long departed and much beloved husband, who's spent a lot of time thinking about federal provincial relations. But if you were to think about it, when you think about the Canadian space for making change, it's always about the relationship between the federal government and the various provinces, provinces in relation to each other. But 65, 66, as you put it, Carolyn, was a particular moment of possibility. And one of the great ironies is that all this was done when Lester Pearson ran a minority government. Very interesting that it was possible to do then. These days, it's hard to think that a prime minister running a minority government in Canada could get much done in healthcare. So,
and that brings a little bit the question of, is it about healthcare? Is it healthcare that's so complicated because of the power of doctors, because it's so close to it's so expensive, and there's this. I mean, we've been trying to get the right answer on this healthcare questions for many years. So, do you think that your book? I mean, you mentioned, I think that it is applicable. The framework is probably applicable to environment, to many other policy questions, but healthcare seems to be a particularly difficult dossier, if I may say. Carolyn.
Yes, I think so. Healthcare is a hard case. In this, it's hard to make change in healthcare. So it's actually a very rich field to study for that reason. Because I've said it in another venue that it's sort of like the genetically engineered mouse of social policy. You know, it's just it's got traits that make it particularly susceptible to resistance to change. But so I did in the book try to speculate a bit on the application of the framework to other areas. It was already 700 pages, so I thought maybe I'd better, draw a line under this somewhere. But if you look at other things that governments did, the same governments I'm looking at did at about the same time, you see some interesting parallels. The Obama stimulus was like a dry run for the way they had to cobble together Obamacare. The Kelowna Accord under Paul Martin was a very similar kind of arrangement with the provinces as the Healthcare Accord of 2004. So I don't think it's necessarily specific to healthcare. I think healthcare, as I said, is a hard case that really points up these strategic calculations.
Habiba, what do you think?
If I may add, in the United States in particular, not only are there many class and institutional issues which are very serious, it's 20% of the GDP of the richest and most powerful economy on the planet. The amount of money, the amount of power that goes with money flowing through that system is so great. I have no idea how they've managed to change anything at all. It's, there's just so much at stake, quite separate from the fact that people care a lot about access to good health care, about the capacity to stay healthy as long as possible, about care for the people they love, about all those things that healthcare means. It's just such a huge pile of money that I really don't understand how anything happens there.
Yeah, that's such a good point. I haven't done the calculation recently, but it certainly has been the case over time that the US healthcare economy is larger than the healthcare economies of all other OECD nations put together. So there is just a scale phenomenon here that cannot be ignored.
Well, also on this scale phenomenon, I was struck by the blueprint, the idea that we imagine the future, we create the shadow of the future, as you described. And I was thinking whether it relates also to ideas of a deliberative democracy, which is you need almost ideas to percolate for a while so that people get comfortable with them, then they start imagining what it could look like. And so, and I was struck by the fact that you have one example, and it seems fairly limited to the Netherlands in a way, like this sort of sense of ownership of public policy forever of a particular party. But I was impressed by the fact that you thought maybe environment or the Green New Deals might be part of a blueprint more phenomenon. So I'd like to hear you about whether ideas need time to percolate, and maybe that's why blueprints might be a good model.
Right. So the blueprint model is the great tragedy of the book, right? It's such an attractive way to do things. It's a policy wonks heaven. You get to sketch out the broad parameters and then only put it in place over time as you develop it. It's so rational. And not only that, not only, so you're able to achieve this very rational long-term change with minimal conflict. So it's nirvana from a policy and political perspective, but it is so rare. It is so rare that a government is willing to take the risk of extending beyond its current mandate in its strategic plan. So yes, I mean, so that is the great tragedy of the book. It's not, and I give examples of other cases in which blueprints were attempted and failed because the conditions changed too rapidly. Ireland is currently trying a blueprint model for healthcare. We'll see. It's been underway for some time without success. So we'll have to see how that plays out. But it's not impossible. What if we abstract a bit from the Dutch case and we say what was it that brought that about? It was the depth and breadth of the consensus. So if there's something else that could create that deep and broad consensus across society, it was possible in the Netherlands because of coalition governments and corporatism. But if there's some other way of creating that kind of deep, broad consensus and the shadow of the future, we could do a blueprint over time. And maybe those who argue, I'm not among them, but maybe those who argue that this current moment is creating that deep, broad consensus for something like a Green New Deal. I hope I'm wrong, but I don't see that. But some others do, and if it is, and if we can establish that shadow of the non-carbon future that everybody has to be adjusting to, then we can move in that direction.
Any comments, Habiba, on this? Do you see it?
I don't. I wish I did, but I don't. Though I do see that the entry of players I wouldn't have expected on the side of changing the world toward what some people call the Green New Deal is much greater than there are more players interested in it than I thought. I didn't expect finance and the large businesses to try to do their version of an analysis of what this is all about. There's clearly a huge generational difference in who cares about this and how much they care about it and what they're willing to do to live the change and bring about the change. So I don't want to say that I don't see it happening in the way that it perhaps should, but I'm worried because many things I've hoped for that seem completely rational to me haven't happened. And it's either that I overestimate the rationality of my fellow humans, or they think I'm very wrong. It's worrisome. I don't see it happening as quickly or as I think is necessary. And it does seem as if sometimes the human race needs to have its face right up next to the catastrophe before it acts. And the current situation of the pandemic is a perfect example of we're right up against the catastrophe. What are we prepared to do as a result of what we've now learned about the failures of our various systems, about the pressures on the various caregivers out there, about the number of fellow humans who seem to have, I'm sorry, I think they're not mentally well in the way they're reacting to all of this. So I don't wish to rediscover the flaws in the human race, but the older I am, the more I rediscover them day by day, including the flaws in myself, if I may say so. I wish, Carolyn, do you have any views on what could actually come on the healthcare side out of the current situation we're in, say in Canada? Do you see anything coming out of this that's actually going to happen? Are we going to do something about long-term care, or are we just going to, blow our noses and go on?
I think there's a real prospect for doing something in long-term care. I can't show it at this point, but I looked into media coverage, for example, of long-term care over the last decade, long-term care as an issue for government.
Right.
And I have never created a graph like that in my career. It simply takes off in the number of mentions of long-term care in a government context in English language newspapers in Canada over the course of 2020 is just, it's a hockey stick. It just takes off. And so I think we have riveted attention on the sector, and the tragedies are so apparent and so dire that I believe that governments will need to take action. Now, I have some ideas about about what action should be taken. I'm flogging a proposal for a long-term care insurance plan that would bring together federal and provincial governments. So this is not the institution of federal standards, the imposition of federal standards on the provinces. It would be jointly developed standards administered through a long-term care insurance program and enriched with the administrative data and improved over time with the administrative data that would be possible. Would also be an important new source of revenue. So I'm hoping that ideas like that will take root. Ideally, I would like to see a commission, not yet another commission of inquiry to investigate what went wrong. We know what went wrong.
We know what went wrong.
To develop a policy framework going forward, a whole commission for long-term care, and it's possible. I've just lost you.
Oh, well, it's because we have questions from our viewers, and I will get back to that. But Judy Watson asked, we have been discussing the need for new long-term care models for decades. Post-pandemic, do you think there might be a Big Bang possibility? And I think you were just talking about it. So is your idea a Big Bang one?
Yes, I think it would be comparable to the adoption of the CPP, the Canada Pension Plan, or to Medicare, the physician insurance program in the 1960s. It's somewhat smaller scale first of all, just in its scope within the healthcare system, and also because my proposal would actually build on existing models, namely the pension model and the OAS-GIS model. So it's not a creation of a whole new model from scratch, but it is an adaptation of an existing model to create a new institution for the financing and governance of long-term care. So my graph with the two axes actually covers quite a lot of territory. So I would put my proposal. Thanks, Matt. So I would put my proposal toward the lower end of the upper right quadrant there. That it's in Big Bang territory, but it's not way up there in Big Bang territory.
So it's a small Big Bang.
You would think that there'd be a huge audience for this, because all of us who don't die young are going to be old, and we probably don't want to be old for only 5 minutes. And all of us have people in our lives who we hope will be old, and some of them will need care that cannot be provided for them in their home with family members able to help them. So it's pretty clear not only that there are a lot of voters who are going to be the people who benefit from a decent long-term care system, but also people who care about those people, even if they believe they will never be old. That means they're 21 today. They believe they'll never be old, but they will be if they're lucky. So, I mean, there is a huge population at stake here, a very large part of just not only the voting public, but just the actual population of our country. That should drive something forward. That doesn't mean it will.
Well, so for your proposal to work, if we take your Big Bang, even if it's on the a little bit closer to the center, it still needs to build coalition around it. So how do you build a coalition around your proposal? I mean, there's a social aspect to it, so maybe you get certainly the more left-wing people to think about it, but other coalitions that you want to bring, because I think your coalition building is political, but it also almost is social and interest-based, isn't it?
Right. So my book focuses on the building of political coalitions, and underlying those, of course, can be social coalitions as well. But I really do want to emphasize that if changes like this are going to be made, they are going to be made because of the strategic judgments that politicians make, and so. So what's the political coalition that can be built around long-term care? I mean, even, frankly, I don't think this will occur until after we have a post-pandemic election at the federal level. We'll see what happens then if the Liberals remain in minority with support from the NDP. One could imagine that coalition and a number of provinces who are eager for the funding that would enable them to improve their long-term care programs. So even if the Liberals continue in minority, we could get this results. If they come back with a majority, good question. Will they be redoubling on childcare, or will they actually see this as the bookend at the other end of life in the care economy? But in either case, they're going to have to build a coalition with the provinces. I think the provinces have an incentive, even though they resist the imposition of national standards. My model would not be the imposition of national standards. It would be a jointly owned approach. Yeah.
Yes, I think
we're coming. That's true. We're coming to the end, and I mean, we've been discussing. There were so many other questions I wanted to ask you, but I'm just going to ask as we conclude whether you want to. Make some reflections about the project, how you got to that project. And Hadviva, I was struck when I was reading it. I was reading it a little bit about the former politician as well, and where intuitively you know that politics is the art of the possible. So the model seemed to speak to me about some discussions that I had heard about, do we do this or do that, and so on. So how do politicians could use this book? How should they read it? And secondly, Carolyn, the audience of the young researchers out there who's looking at this book and say, how did she get there? Like, what's the project? So let's start with you, Hadviva, and I want to leave Carolyn the last words.
Well, I mean, it seems to me that politicians who get elected because they want to do good to the world would be very interested in that project. I completely agree with Carolyn. It cannot be the federal government describing what the standards are. That's ridiculous. It never works. It never could work. The only people who could come together to describe what needs to happen are people who actually work in the sector, understand what it actually takes to give people decent care, who understand about investing long-term as well as short-term money. It's not going to be, the design should not come from the top of anything. The real question is, can a bunch of well-informed people who've worked in this space, both the financial space and the caregiving space, come up with something that makes sense to most Canadians and that will work? I have no doubt that the intellectual capacity to do so exists in the country. Whether the ability to put together the people who could work together to get there, whether there is a willingness to do that is not clear to me, but I hope that it exists. So I don't think this is beyond the talent of humans living in Canada to do a good job on. And I actually don't think that it needs to be highly combative and a source of conflict. It's about the creativity required to make this whole space better, both financially and in terms of the quality of care that people get. So it's really, are we interested in opening that door?
So, Carolyn, the last words to you.
Okay. Well, that I'm very much encouraged by Habiba's last point. And remember that when we did bring in universal physicians insurance in the 1960s, all of the parties supported it in the end. So we might expect the same thing in long-term care. Just, you asked for a word to scholars at the early stages of their career about how to go about a project like this. Well, I won't downplay the amount of time and effort that goes into it. It is really interesting, though. It required me to use a broad range of methodologies. I did a lot of interviewing. I did a lot of documentary work with primary and secondary documents. I, of course, traveled to all of the countries under review more than once, talked to many people. But it was a multi-year project. And I developed insights along the way. I thought I knew what I was going to argue when I entered it, and it's always interesting to learn as you go. So it's worthwhile. It's worthwhile. It's a big task because you have to understand something about healthcare, about the technical aspects of whatever policy area you're working in, as well as the broad politics. But it's hugely rewarding.
Well, let me conclude by saying, let me just bring the book, Remaking Policy. It's well worth reading for people to understand what's at stake in making big decisions for our country that we need so badly. So thank you, Carolyn, for sharing your book and your wisdom. Thank you, Habiba, for being there again and sharing your perspective and your wisdom as well. And thank you to our technical team, Matt Glanfield and Alyssa Gainsbourg. Thank you for making sure that we're here together. So see you soon.
Thank you, everyone.
Thank you so much. Very enjoyable.